Welcome to the Explainer. Today, we are diving deep into vasodilators. These are the meds that help relax blood vessels. But we're not just going to talk about how they work. We're going to break down where they work. And believe me, that distinction is absolutely critical when it comes to treating cardiovascular disease.
So, to really get a handle on this, I want you to picture something. Imagine your body's entire circulatory system. All those arteries and veins is just a super complex plumbing network. Now, what do you do when the pressure in that network gets way too high? Well, you can't just shut off the main valve, right? You need a much smarter, more precise solution. And that's exactly what these medications are designed to do.
All right, so here's our game plan. We're going to start with the big picture of this plumbing system. Then, we'll look at the drugs that hit the arteries, the ones that target the veins, and, you guessed it, the ones that do both. And to wrap it all up, we'll explore that totally unique, low-pressure circuit that runs through our lungs. First things first, let's get a key concept down. In our body's plumbing, not all the pipes are the same, not even close. They have very different designs because they have very different jobs. So, on one side, you have your arteries. Think of these as your resistance vessels. They're strong, they're muscular, and their job is to create pressure. It's kind of like when you put your thumb over the end of a garden hose to make the water spray farther. That's resistance. Now, on the other side, you've got your veins. These are the capacitance vessels. They're more like big, flexible reservoirs that just hold on to a huge amount of your blood at any given moment. Okay, so with that in mind, let's start with the drugs that go to work on high-pressure side of the system, the arterial dilators. And that brings us to a really important term, afterload. In our plumbing analogy, afterload is basically the back pressure that the pump, your heart, is fighting against. With every single beat, your heart has to generate enough force to overcome this resistance from the arteries. And the way we measure this resistance across the whole system is called SVR, or systemic vascular resistance. So, arterial dilators are smart. They work by telling the smooth muscle in those artery walls to just relax. When that happens, the SVR drops, which directly lowers the afterload. All of a sudden, the heart doesn't have to work nearly as hard. And that's why these drugs are so fantastic for things like high blood pressure or for helping out a heart that's struggling. So what kinds of drugs are we talking about here? Well, a classic one is hydralazine, which really loves to target those arterial vessels. But another huge group is the dihydropyridinous calcium channel blockers. You've probably heard of these. Common ones are amlodipine and nifedipine. And this is just a brilliant illustration of how selective these drugs can be. If you focus on the right, you'll see the dihydropyridines, or DHPs, like amlodipine. Notice how their effect is almost entirely on the blood vessels, the arterioles. Now compare that to the non-DHPs on the left. See how they affect not just the vessels, but the heart muscle and its electrical system too? This selectivity is everything when it comes to picking the right tool for the job. Okay, let's switch gears. We've talked about the high-pressure arteries, but what happens when we target the other side of the system, those low-pressure veins that act as our body's main blood reservoir? Right, so if afterload is all about the pressure the heart pumps against, then preload is all about the volume that's filling the heart before it pumps. It's the amount of stretch on the heart's walls right at the end of its filling cycle, just before it squeezes. Venous dilators, a classic one being nitroglycerin, work by expanding those big, stretchy capacitance vessels. This lets the veins hold on to more blood, which means less blood is returning to the heart to be pumped. By dialing down the preload, you seriously reduce the heart's workload and how much oxygen it needs. This is a game changer for conditions like angina or for reducing fluid buildup in heart failure. So how does this actually work on a chemical level? It's pretty amazing, actually. Drugs like nitroglycerin are basically nitric oxide donors. They release this tiny little molecule, that's step one, and it kicks off a whole chain reaction inside the vessel wall. The end result, what really matters, is step 5. The smooth muscle just relaxes. It's like flipping a biochemical switch that tells the vein, hey, open up, hold more blood. So let's just boil this down to the key difference. Arterial dilators, they tackle the pressure problem by reducing afterload. Venous dilators, they tackle the volume problem by reducing preload. One makes it easier for the heart to push blood out, the other just reduces how much blood the heart has to deal with in the first place. But of course, medicine is rarely that simple, right? It's not always black and white. A lot of drugs don't just pick a side. They take a more balanced approach and dilate both the arteries and the veins. And this group includes some of the most widely prescribed cardiovascular drugs on the planet. I'm talking about ACE inhibitors and ARBs. They're cornerstones of treatment because they do both. They tackle the pressure problem and the volume problem at the same time. And in the hospital, in more critical situations, we can use a powerful IV drug like sodium nitroprusside to get that same balanced effect, but really, really fast.
Okay, so far we've only been talking about the main plumbing system that goes to the whole body. But we have another totally separate loop we have to talk about, the pulmonary circuit. This one just runs between the heart and the lungs. And it's so important to get this. This circuit plays by a completely different set of rules. I mean, just look at the difference here. The resistance in the body's main circuit, the SVR, is huge. But the resistance in the lungs circuit, the PVR, is about 10 times lower. It is, by its very design, a low-pressure, low-resistance system.
The pulmonary circuit is also really special because of how it reacts to things. For instance, in most of your body, if an area is low on oxygen, the blood vessels there will dilate to try and bring in more blood. But in the lungs, it does the complete opposite. Low oxygen makes the vessels constrict. This is a critical reflex, and it's called hypoxic pulmonary vasoconstriction.
And you might think that's a flaw, but it is an incredibly smart design feature. This reflex automatically shunts blood away from parts of the lung that aren't getting good air and redirects it to the parts that are full of oxygen. It makes sure that your blood flow is perfectly matched up with where the oxygen is, maximizing the efficiency of every single breath you take.
So what's the big takeaway from all of this? It's that vasodilation isn't a sledgehammer, it's a set of precision tools. The next time you hear about a blood pressure medication, think about this plumbing system. Is it working on the pressure side, the volume side, or both? Is it targeting the main system or that unique low-pressure circuit in the lungs? Because understanding these differences isn't just for textbooks. It's at the very heart of how we manage modern cardiovascular health.